From Microbe TV, this is TWiP, This Week in Parasitism, episode 251, recorded on January 3rd, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about parasites. Joining me today from New York, Daniel Griffin.
Hello, everyone.
What's on the tie, Daniel?
Well, it's a Friday, so that means it's Sexually Transmitted Disease Day.
Wonderful.
It's flagellated, I always say, popular among the ladies.
Is it Giardia?
So close.
Trichomonas.
Trichomonas.
You got it. It's trichomoniasis.
But you know, the last TWiP, you said that 85% of women have undiagnosed giardiasis. Was it? Or was that trichomonas?
I think we were talking about trichomonas.
Okay. Giardia is from water, right?
Beaver fever, right? Drinking the water.
So Giardia is not a STD, right?
No. Well, I'm going to say no. And maybe when we introduce our guest at some point, we'll talk about, there is a higher incidence in certain populations and there is a sexually transmission mode, but in general, it's not considered a sexually transmitted pathogen, but it can be transmitted sexually. And we do see a higher incidence in certain populations. And yeah, just before we started, we briefly were talking about the weather, and I will chime in and say it is really cold.
Yes.
I got a run in right before this, and yeah, I cut that run short.
Also joining us from Glasgow, Scotland, Christina Nowla.
Hello, everybody, and sorry for jumping in too early. It's also freezing cold here. I didn't try for a run, but I did some pavement ice skating. I think not very elegantly and not deliberately, but yeah, it was really, really cold and freezing.
Our guest today is from Columbia University Irving Medical Center, Jorge Cardenas. Welcome to TWiP.
Hi, thank you so much for having me.
You are a infectious disease fellow there, is that right?
Yeah, that is correct.
Okay. And you know Daniel already, right?
Yes, I know Daniel very well.
All right. Well, you contributed the case we're going to crack this today. So Daniel, why don't you tell us a little bit about it?
All right. I will remind everyone, and at the very end, Jorge will actually tell us what the diagnosis ended up being, how it was made, how they were treated, and how things turned out. But as I presented last time, we had a woman. She was in her 30s or 40s. We'll find out maybe her exact age. And she had gone to Belize with some of her girlfriends. And when she got back, she had noticed a lesion on her face. She goes to several physicians, and it was about a 6-month saga, despite multiple visits to different providers, a number of topical creams, this ulcer on her face just does not heal. She actually, it was a friend of hers was a physician who finally said, "What's going on?" and sent her to our office out here in the tri-state New York area. And she was seen by Dr. Fabry, who's actually been on our show before. She and I talked, and then we decided it was time to involve our friends at Columbia to help us with the diagnosis.
Uh-huh. So that's where Jorge gets involved with it?
Yes, actually, Shauna, who's also been on, she's involved. Jorge is involved. It's
okay.
Everyone's getting to meet all of the crew.
All right, we had a bunch of guesses. Some of them are really short, as you will see. So, Daniel, why don't you start with that? Why don't you do the first two?
All right. So the first is Josh writes, "Thank you for this very interesting case. I suspect this is a case of localized cutaneous leishmaniasis." And that's Josh Gray, a PGY3, Department of Medicine, Duke University Medical Center. Maybe someone who's going to go into infectious disease. Steve writes, "Botfly." Okay. And Jason writes, "Greeting TWiP hosts. I'm writing from within the confines of the Amazon Spheres Botanical Building in Seattle, in which it is a humid 22 degrees C outside the massive geodesic Structure, it is 12 degrees C and unusually dry for this time of year. In episode 249's case of the facial ulcer in a returning traveler, the patient appears to present with cutaneous leishmaniasis, a parasite-focused differential diagnosis of a patient presenting with a cutaneous lesion, and history of exposure to the flora and fauna of Belize includes cutaneous leishmaniasis, tungiasis, cutaneous larva migrans, onchocerciasis, myiasis caused by the New World screwworm fly, which I think our listeners are familiar with, myiasis caused by the human botfly, and arthropod bites such as fleas and ticks. In the current case, the geographic exposure coupled with a persistent painless skin ulcer is highly suggestive of cutaneous leishmaniasis. This disease is caused by infection with one of the many species of Leishmania protozoa. In the New World, these flagellated parasites are spread via the bite of Lutsamia species sandflies, which are prevalent throughout Central and South America. Diagnosis of cutaneous leishmaniasis is best done via PCR. If PCR technology is unavailable, then a diagnosis can be made via microscopy of a skin scraping. In the case of the later technique, the border of the ulcer is sampled via needle aspiration, a Brock curette, or a biopsy punch. The sample is then applied to a slide and stained with both May Grunwald and gymcystains to achieve a panoptic effect. Presence of Leishmania amastigotes confirms the diagnosis of leishmaniasis. Treatment for cutaneous leishmaniasis includes pharmaceutical options such as sodium stibogluconate or pentamidine. Warm regards, Jason, a returning champion.
You see, he listened to you, Daniel, because you said, why don't you write returning champion if you won a book? And he listened.
Yes, thank you.
All right, Christina, can you take the next one?
I can, yes. Courtney writes, hi all. First, I want to thank you for all you do and for providing such interesting discussions. This is my first ever guest, and apologies if I'm way off base. I am an accountant by trade. I came to Microbe TV and TWiP by chance because I didn't feel very good at all for about a year, and no medical practitioner I saw was able to quite pin it down. So without answers, I, of course, went to the internet, and here we are. I'm feeling better now, thanks. Anyway, enough about me. In TWiP 249, I'm going to guess cutaneous leishmaniasis caused by leishmania. My research led me to this conclusion based on the description of the painless facial lesion and this parasite being endemic to South America and Belize, where the subject travelled. Thanks again, and see you all next TWiP. Courtney.
Jorge.
So next reads as El Hadi writes, the description of the patient's face sounds like an insect bite. The fact that it developed from a papule and eventually into an ulcer makes me think of a potential infectious cause, but cutaneous leishmaniasis comes to the front. I hope to hear the answer soon, and thanks for this interesting case, El Hadi.
Why don't you do the next couple also, because they're really short.
So Margaret writes, CL, cutaneous leishmaniasis, and Crypto Grandma writes, cutaneous leishmaniasis.
We've got a fun bunch of listeners. Crypto Grandma, I like that.
Yeah, it's pretty funny. All right. Did you go, Daniel? I don't remember.
I think it's you. You get to go now.
All right. Sherry writes, my guess for this case number 249, RE lesion on the face after visiting Belize is Leishmania mexicana. Let me know if I'm correct, please. And Sherry writes, go big red, which of course is Cornell. And probably Sherry doesn't know that I'm an alum, but I'm probably much older than she is. All right, back to you, Chris. Who started? Daniel started.
I started. So Ben writes, hello all, cutaneous leishmaniasis. Miltefosine local therapy, either putting liquid nitrogen on it or microwaving it. Also, go kill the sandflies to protect the next person. Ben in New Haven, returning champion. And then he gives us a little bit of some extra not related stuff.
Christina.
Leo writes, greetings, distinguished professors. I'm going to go out on a limb with our intrepid Belize traveller. Although I do not have any medical training, I have played a doctor on TV. That's another interesting listener. Probably not Dr. House. Based on my non-existent training and underwhelming reviews as a television doctor, my guess is that our subject has contracted Echinococcus granulosus, also known as cystic echinococcosis. I would treat our patient with albendazole 400 milligrams orally by BID for at least 4 weeks. In addition to the albendazole, I might throw some praziquantel at it just because, and just in case surgery may be required. A treatment of do nothing and wait and see are another valid treatment option. The chemotherapeutic treatment could be administered later, depending on how the patient responds. My diagnosis is a little out of the box, but they don't call me Longshot Leo for nothing. Very truly yours, Leo, from California.
House was wrong often too,
He was, yes, he was. Quite spectacularly so.
Yes, Dixon likes to point that out. Yeah. Jorge, you're next.
So Christian writes, Dear TWiP team, greetings from Austria, where temperatures have now reached below 0. Just saw the short and very nice format of a case. My guess would be cutaneous leishmaniasis after a bite from a New World sandfly. As New World leishmania can cause mucocutaneous spread, additional investigations by an ENT doctor would be recommended. Diagnosis should be done with a PCR, as the treatment is species specific and the area is endemic to at least 2 different species. Because the lesion is in the face, a lesion aspirate would be preferred to a punch biopsy. Treatment is then depending on the species, but would most likely be systemic, as local infiltration in the face is not nice, and the species in the area have a certain risk of systemic spread. Treatment options would be pentavalent antimonials, liposomal amphotericin B, or multefusine. Merry Christmas and Happy New Year to the team. Christian.
Stacy writes, Hi all. This is about the new case study in TWiP 249. Woman returns from Belize and discovers a facial lesion. I'm not a medical person, so I first did a Google search to get my bearings. I searched for parasitic diseases that cause facial ulcers and are endemic to Belize. Google AI brought up cutaneous leishmaniasis. I then typed the question of why a facial ulcer caused by leishmaniasis would not heal on its own. The AI response was that a slow immune system response, along with persistence of the parasite in skin immune cells, made it difficult to eradicate. Having just listened to TWiP 249, I then looked at my downloaded copy of Parasitic Diseases, Volume 7, and gasped at the photos of lesions. If leishmaniasis is the cause, the woman returning from Belize would have picked up her infection from the bite of a sandfly, given that no immune-compromising co-infection, medication, or autoimmune disease was mentioned, and given that no further lesions developed, I'm assuming that the infection had not spread to the mucosa. A test to determine the exact species of leishmania would be necessary before determining a course of therapy, and Parasitic Diseases recommends NAT techniques. In a case study of a boy from Belize with 2 lesions published by the Journal of Pediatrics, biopsies looking for amastigotes and PCR determined the infection to be Leishmania mexicana. Current therapies offered for a leishmania infection can have severe side effects, and I'm no doctor, so I'm not going to attempt to choose one for this patient. The boy with Leishmania mexicana improved after 3 months of careful wound care, and I'm hoping the same turned out to be true for the traveler to Belize. I'm looking forward to what therapies were chosen and what you all consider to be the best. So my guess for this case study is Leishmania mexicana. Since I already downloaded the book, please don't include me when you draw a number. I rarely try to solve cases, but I always listen and enjoy your discussions. This and TWiP remain my all-time favorite podcast. Thank you. All right, back to you, Daniel.
All right, Steve writes, Hi, parasitastic purveyors of pertinent podcast knowledge. It has been quite a while since I submitted an answer, mostly because I'm usually occupied while listening to TWiP and forget to go back later to submit one. My first thought for the 30s to 40s female was a 6-month facial lesion after travel to Belize was cutaneous leishmaniasis due to the persistence of the lesion without spread to other areas or tissues. Just for fun, I fed a copy of PD6. For some reason, I didn't see my 7th edition PDF on my phone and was lazy, into ChatGPT, as well as the patient history to see what it would give me. While it did give a parasitic differential, none of the other suggestions matched, since all of these suggestions involve the spread of parasites to other tissues or to other skin regions on the body. Tinea rashes likely would have resolved with topical ointment, as would most other common causes of dermatitis, while chronic skin diseases would be unlikely to stay isolated to one area and would either spread or resolve and recur in other areas. As she was in an endemic region, spent a great deal of time outdoors, and was bit by insects, CL seems the most likely diagnosis. Treatment would most likely be liposomal amphotericin B or miltefosine. I'm not a clinician, but I would imagine miltefosine would be the first-line treatment since it is available as an oral drug rather than requiring IV infusion. From what I read, both have some nephrotoxicity, but I was unable to determine which had a higher incidence. I have not yet received any physical copies of parasitic diseases and would love to have a PD7 if I win the drawing. Thank you for this from this long-time lurker, Steve in the Eastern Sierra.
Christina.
John writes, still hoping to win the book. After hearing this case presentation, I was excited because I felt I could recall cutaneous leishmaniasis from memory and even hear bits of Dixon's dialogue in my head from the videos and course. I had to drive my parents a distance over the holiday, so even told them what I knew and how I knew, plus that the sandfly rang a bell as a vector. I was pleased to confirm that in the textbook later. CL mexicana is endemic to Belize, and drawing from the textbook, NAAT would be the testing, so that would be, I suppose, nucleic acid-based tests, PCRs, would be the testing, which I think we would call, there we are, what we call PCR now. I should read faster than I speak. Treatment was less clear, so I will look forward to find out what was actually done. CL can clear without treatment and good hygiene for some. Other methods are cryotherapy, thermotherapy, and topical paramomycin. However, there is a note that side effects can accompany the types of drugs that apply to CL. Humans are a dead-end host, and it appears for most that immunity is attained after initial infection, so she should be able to go back and enjoy her next trip after this hopefully clears up. Happy New Year, everyone.
Jorge.
Rich writes, as a retired doctor from UMass Health Service in Amherst, I'm now a vaccinator from the town and found the TWiP YouTube very informative. Out of curiosity, I watched this episode of TWiP, and over the years, I saw patients that traveled internationally that had single skin lesions. They often had bacterial infections, but occasionally unusual lesions such as butterflies, larvae, and cutaneous leishmaniasis. Since this is a parasitology video and the lesion is long duration, I will go with leishmaniasis as the cause of this woman's lesion. Happy New Year.
Ed writes, new case, fly bite. Cutaneous leishmaniasis seems best bet. BX diagnostic. What's BX?
Biopsy.
Biopsy diagnostic. Treatment varied, but I've had good response with heat alone. So this is a comment on the last episode. That's about HTLV1. Oh, okay. By the way, other very significant pockets of HTLV1 are present in the Windward Islands, with 1 to 3% of the population infected. Therefore, this must exist in Brooklyn with the great number of West Indians in that area near downstate, also London and Toronto. So many cases of hyperinfection syndrome in the Grenadines, devastating disease. Thanks for the great educational site and fun. Okay, back to you, Daniel.
Justin writes, hello, dear hosts. For the patient with a painless lesion on her face after returning from Belize, my guess is cutaneous leishmaniasis. This is due to leishmania being endemic in Belize and the very typical symptoms. As for treatment, since this case seems to be cutaneous and not visceral, amphotericin B would not likely be used due to the side effects. Miltefosine might have been used, but warning should be given to the patient since it can cause birth defects if the patient becomes pregnant within 3 months. Knowing what species of Leishmania is present would be helpful since miltefosine may not cure L. major or A. brasiliensis infections. Perhaps this was determined via PCR test. Thanks as always for a wonderful podcast.
Christina.
Eyal writes, Dear Vincent and the sages of the microscopic eukaryotes, Happy New Year from Sydney, Australia, where the cicadas never stop serenading. Oh, I would love to hear some cicadas now because it would mean summer, wouldn't it? Non-healing ulcer after visiting Belize. My immediate intuition would be leishmaniasis. After a quick Google search, I would even refine my guess to L. brasiliensis. Considering that L. brasiliensis is somewhat resistant to treatment, I would assume Daniel would want her on the new generation of treatments such as amphotericin B. Hope the treatment is successful and the lady makes a full recovery. Wish you all a year of peace, happiness, love, joy, good friends and healthy family. Eyal.
Jorge.
Kimona writes, Happy 2025 to you all at TWiP. I think this woman was subjected to a sandfly bite of Luxomia species while in Belize and developed a cutaneous leishmaniasis infection endemic to the region. Gems stain of a skin biopsy from the edge of the ulcer may reveal intracellular mastigotes. PCR also has a great specificity and would allow species identification and tailoring of treatment options. L. mexicana appears to be a common cause of cutaneous disease in Belize, whereas L. brasiliensis also has a propensity to cause mucocutaneous disease. Perhaps the friends at Columbia helped with the PCR and species identification. Treatment is determined by location and extent of lesion, species identification, but also drug availability and cost. Not sure how long she has been trying various topical creams, but I suspect it is not resolving on its own. Since this is a facial lesion on a young woman, a more aggressive systemic choice like lipoamphotericin B or miltefosine may be in order. Warmest New Year's wishes, Kimona.
I'm not sure if Kimona won a book already. Do you know, Daniel? Do you remember?
I suspect she has, but I do not know.
All right, we'll leave her out then. One more from Paul. My diagnosis for the facial ulcer in the visitor to Belize cutaneous leishmaniasis. Thanks to you all for your continued work. I have a copy of Parasitic Diseases, so take me out of the draw. Okay, I will. There you go. Okay, Daniel.
All right. Well, we had a lot of guesses here, but I think, Jorge, we still have a couple more folks to guess before you tell us what's really going on. So, Christina, you want to go first?
Yeah, I sure can. So with my parasitic tunnel vision goggles on, I was immediately thinking of cutaneous leishmaniasis. But then I was thinking in Belize, we have Leishmania mexicana and also Leishmania brasiliensis. So I think I would probably want to have an accurate diagnosis down to species before considering treatment because Leishmania brasiliensis can potentially also result in mucocutaneous leishmaniasis, and I think that I would consider that for my treatment. So yeah, that's my guess, short and to the point.
All right, Vincent.
All right, when I heard this, I immediately thought cutaneous leishmaniasis because I remember, so in the early days of TWiP, Dixon gave lectures on individual parasites, and one of them was Leishmania, and he showed a picture of a young lady with a lesion on her face. It was really big. It was almost an inch in diameter, and it stuck to my in my head since then. And he said it was very difficult to get rid of this, especially in under-resourced areas. They don't have the money to get it fixed and so forth. So it sounded like that to me.
All right. So Jorge, I mean, can it really be that easy? Can it's 6 months of visiting all these specialists, and yet our hosts and all these email writers just quickly picked up on it being, what's going on?
Yeah, so this was a really sort of pleasant lady, really, I think, kind of learned a lot and had a lot of kind of fun taking care of her. She, like you had suggested she traveled to Belize for about a week, and she did a lot of sort of tourism and, hiking around the jungle areas, but never sort of reported any mosquito bites. And then like 2 to 3 weeks after she came back, she started to notice this sort of, she initially reported like a tender nodule in the face, which was sort of progressively enlarging. As Daniel suggested, she tried a lot of sort of topical therapies, and saw other kind of outpatient providers. She, I think, did about 3 to 4 courses of antibiotics as an outpatient, counting doxycycline and trimethoprim sulfa. And she also got steroids injected into the lesion, which she actually reported that improved her pain after sort of both the antibiotics were given and the steroids were administered. And she did have one biopsy after the second steroid injection, which was inconclusive. So actually, sort of at the time that I saw her, she had already had a second biopsy, and the results of the biopsy were already kind of available to us. So we kind of missed that whole, fun diagnosis part because sort of the results were already done.
And what did they show?
So, yeah, I mean, I think everybody kind of really hit the nail on the head. The biopsy after 6 months showed intracellular amastigotes consistent with Leishmania species. And so the pathology was sent to the CDC for PCR testing, and ended up showing Leishmania mexicana, which, it was sort of kind of really important for us, I think, to learn the diagnosis, as you have all alluded, and as I also kind of learned during this case. So, I think that we, before even the results came in, I think we had a long sort of discussion with the patient regarding all of her treatment options. And I think some of the viewers already kind of hinted towards this, including like, local therapy versus systemic therapy and how would both would look like. I think, even though Leishmania mexicana ended up being the resulting species that was involved in this lesion, and which carries very kind of little mucocutaneous dissemination. This was a young woman kind of with a lesion in her face. It had been already enlarging for about 6 months. And I think by the time that we had seen her, it was about 4 centimeters in diameter. Wow. So I think, sort of mutual kind of discussion, we proceeded with systemic therapy. And we discussed both the option of doing, intravenous kind of liposomal amphotericin B versus moltefosine. And we were able to kind of coordinate getting the moltefosine for her. And I think kind of doing an oral option would be, it was kind of ideal for her. So that's what we kind of ended up doing for this patient.
How did she respond? How's she doing?
So she actually ended up doing really well. Her lesion completely sort of did complete re-epithelialization at her last follow-up, which was about like 6 weeks ago. And this was like 6 weeks after she had stopped her moltefosine. So she completed 28 days of therapy. I think some kind of really big take-home points that I kind of learned from this case that I don't think I kind of knew, from the get-go, is that I think like the biggest side effect with moltefosine is GI side effects. And a lot of people do complain of a lot of nausea and dyspepsia. So this is sort of the warning that we kind of, that I was kind of taught on to kind of discuss with the patient. So when we provided when we coordinated the medication for her, and we coordinated actually with the company that sort of distributes multiphysin in the United States, they recommended us to do like antiemetics preemptively with each dose. And she ended up like reporting a lot of kind of nausea and dyspepsia. And the second thing that I don't think I had kind of realized, that I think one of the viewers also pointed out, is the risks of like fertility issues and issues with pregnancy. So, she already had sort of one like contraceptive method in place. So that wasn't sort of such a big concern, and she desired no future children. So I think, but that was sort of something that we discussed, and I thought it was sort of a good learning point, because I don't think it's sort of that like I didn't know this kind of coming in before. But yeah, I think sort of she recovered really, really well.
Can she get infected again with L. mexicana?
So I do believe that you can get reinfected with leishmania, but I would sort of defer also to you experts if you have another opinion. But that was my understanding.
Yeah, it's an interesting history, right? So when we talk about scarification, so particularly some of the old world, and that was really where we have a lot of data, the old world, because the last thing you want is one of these lesions on your face. So in the old world, right, before people like Columbus and others crossed the Atlantic, and leishmaniasis was common in the Middle East and China, and actually maybe China was the first place that this was described. They would actually find someone who had a cutaneous leishmaniasis sore, and this was particularly young ladies. They would scrape it with a sharp metal object, and then they would inoculate them in a less obvious place like the buttocks. And so there is felt to be some protection from prior infection. Now, let's be honest. Here it is, 2024. Have we repeated these studies in the New World? No. So, and actually, earlier today, I just came across my email some studies looking at different antigens, because there is an interest in a leishmania vaccine. Right, because this is an issue. There's research that looking at point of care testing for leishmaniasis, looking at vaccinations, trying to take advantage of some of that immune knowledge to keep, specifically Leishmania mexicana. Would we think in general she's at lower risk? Probably, but boy, I'm not going to go out on a limb and be the one who tells her to go back to Belize and then she gets another facial lesion, right? So.
Right.
But this is great. I mean, this, I have to say, we see a lot of these parasitic cases. This is a really nice resolution. I mean, miserable 6 months. I mean, and forced sonomy. I mean, that's like a huge lesion on a person's face, right?
Yep.
But now to see that the expert, care that Jorge was able to bring to this. And I mean, it's got to be gratifying, right? You feel like, okay, I went into ID and everyone tells me all the downsides, but this has got to be quite an upside.
Yeah, no, I mean, for sure, it feels kind of always good, I think, to see people improve. So really kind of gratifying, yeah.
I like the, even though you say, oh, we already had the biopsy results. I mean, here was a woman who was a mystery for 6 months, which is much longer than a Dr. House episode. And, and then finally ended up in the right place, got the right diagnosis, and then even beyond that, got the right treatment. And as Jorge probably understates, it's, you got to know what you're doing. This isn't just writing a script and walking away. I mean, if she was given a treatment and she didn't tolerate it, and there was not the understanding and appreciation of doing preemptive antiemetics,
Is that a treatment that you would be able to prescribe, or does that something has to come through the CDC, or how does that work in the US?
So we kind of, I consulted with kind of with some people on how the exact kind of logistics were. I'm unfamiliar if there's another route to this, but this is sort of the approach that it was kind of told to me. So multefosine in the United States has to come through the actual company that distributes the medication. So you have to contact the company directly and then kind of work, like you actually speak with the actual CEO of the company and describe the reason why you need the medication to be prescribed. And then sort of he facilitates the distribution of the medication into the local pharmacy. And, it will depend on sort of if the patient has insurance or not. So kind of those details were a little beyond of what I knew. But it's sort of directly through the company. I'm not familiar. I'm not sure if it's available through the CDC.
Yeah, I'm trying to Impavito, I guess, who makes miltefosine. I'm wondering if there are many other drugs that people would be familiar with that they make. But that was also part of involving the folks at Columbia. Navigating access to the drug is not always the easiest thing. I
wanted to go back to something that a listener wrote in quite early on. I can't remember who, but someone mentioned microwaving, and I kind of thought, oh, how would you do that? I presume she meant heat therapy rather than, I don't know, would you be able, I don't know if there's any microwavable devices that you could just hold on, but I presume they meant heat therapy possibly. What do you think?
I don't know, Jorge, if you wanted to field that, but there are these actual, they call them, they're like photodynamic therapies where they'll actually apply a photosensitizer, more sensitive. And then you'll actually use different treatments. Now, there's also a CO2 laser. There is the thermotherapy. And I first saw this down in Peru where they have a water bath and you have these little contraptions. It's basically like a heating bag, but it changes color when it's at the right temperature. It's 50 C. And then you put that on the lesion and you go ahead and you apply that. It's once a week times 4 weeks because these are sensitive. So, but I think the tough thing, right, is this is on this woman's face. And sometimes when you do this, the parasites are in the periphery of the lesion. So you actually risk, damage. I don't know how much we've talked about recently, but headed back to Panama in a couple of weeks. And there, for a lot of the cutaneous lesions, they use pretty aggressive, right? The hot machete, where they heat up the machete and the fire, and then they burn the edge of the lesion, or they take a little bit of the acid from the batteries on the boats that they use, and then they dip that around. Or there's even a plant much like poison ivy, where they sensitize the lesion, and then they come back later, and basically you get that blistering. But again, it's not something you want to do on the face. You're hoping to kill the parasites and minimize the destructive.
Yeah, battery acid on the face? I don't think so.
Thanks.
Or a hot machete.
Yeah.
Oh my gosh.
I think you do present a case like that, don't you, to our students, or you did in the past?
Probably.
Yeah. I do remember the hot machete and the battery acid. Yeah.
All right, let's give away a book. The ones who just gave one word, I didn't include them because I think you should say more than just one word.
Yeah.
Right? So we have 9, leaving out Kimona, we have 9. So we'll pick a number between 1 and 9, and that would be 3. Who is number 3? That is El Hadi. Cool.
Okay.
So El Hadi, you send a letter to an email to TWiP, no letters, an email to TWiP@microbe.tv, subject line TWiP 251 book winner, and then send us your address. If it's outside of the U.S., include your phone number, and we will ship you a copy of Parasitic Diseases 7. All right. So Jorge, tell us about you. Give us your history. Where are you from originally?
So I was born and raised in Caracas, in Venezuela.
Venezuela, huh?
Yeah. And that's sort of where all my family's from. My core family still lives there. And I did medical school in Venezuela. And I wanted to kind of further my training. So I moved right after graduating med school. And I moved to Miami. That's where I did my residency at the University of Miami. And then I came to New York City for fellowship. So currently I'm an infectious disease fellow here.
What originally made you want to be a physician? You have parents who are physicians or something else?
No, I don't, to this day, I don't know how to answer that question because I don't know. Like, I don't know how I ended up in medicine exactly. But I mean, I think I always did kind of gravitate a little bit towards science. I did always enjoy biology, and I really loved kind of human interactions. And but I loved that much that at some point I thought it was going to be, do either like international relations, or at some point I thought of doing philosophy. But, I really thought of something that would be kind of also sustainable in the long term. So, I ended up kind of going through the medicine route, and it's been really kind of incredible.
What is it hard to go from Venezuela to a residency in the U.S.?
Yeah, I would say it's sort of, there is a bit of a challenge because, first, like, you have to, take all of the kind of USMLE exams, which I don't think were necessary, at least sort of from my med school. Like, our curriculum is not exactly like aimed towards taking those exams. So I think it's kind of reframing the content a little bit just so you're kind of good at taking the test. So I think there's a challenge to that. And also I think from a connection standpoint, like, you don't kind of come in knowing many people. So then it's a little hard to, kind of establish those networks that I think are kind of so important.
What are you going to do next when you finish your fellowship?
So I still have a year and a half left. I'm doing sort of a clinician educator track, kind of really passionate about medical education. So I'm kind of hoping just to, do a career in, general infectious diseases, kind of with a focus on like being an educator, a teacher.
So you would be basically at a medical center, right?
Yeah, I think that would be sort of what I would enjoy most. Yeah.
So in Venezuela, what are the biggest infectious disease problems there?
I think there's plenty. But so when I was so in Venezuela, the model is you don't go through this sort of pre-med medical school. So then you just do medical school is 6 years. So when I was a 6th year medical student, I remember there was a really kind of huge malaria outbreak. And sort of when I was doing rotations in the hospital, I kind of also, kind of saw patients in a clinic of malaria. And I think it was something about like 15 to 20 patients a day coming in with malaria. We also, I think unfortunately the vaccination rates may have sort of gone down with time. And I think we were also seeing some kind of vaccine preventable diseases like measles and diphtheria.
Wow.
So, aside from, I think, this more kind of, kind of well-known infections like tuberculosis, that was, I think, kind of really common to remember seeing as a medical student.
How about, is dengue a problem there?
Yeah. I mean, arbovirus is kind of really common. Something I remember like when I was living in Venezuela, like things like dengue or chikungunya or Zika, when they were at like big epidemics, it was like your friends would get it, like, you know, your families would get it. Like you would have people that, you know, kind of hospitalized or just kind of having the illness in their homes. So I think it was kind of a big problem. Yeah.
Yeah. How about yellow fever?
So I do remember when I was a medical student, kind of one of our teachers in tropical medicine, you know, I think like she did mention this a lot, kind of like yellow fever also like only had documented like sylvatic transmission in Venezuela. That was a few years ago. I don't know exactly what's the current situation of that now. But I do remember kind of, you know, it wasn't sort of like when I was living there, at least kind of in my later med school years, I don't remember ever being kind of, you know, like an urban kind of outbreak of yellow fever.
Now, Jorge, you and I have been working on a project, an academic project. Or I should say, you've been working on it.
Yeah. So, you know, I've always been really kind of passionate about infectious diseases. I think this was what I wanted to do, like ever since I was a medical student, because I kind of really fell in love with, you know, kind of the interaction of the pathogen and the host. And I just always kind of find it really interesting. And when I started fellowship, you know, I always also carried my interest of medical education. So I kind of always wanted to combine my interest a little bit and see if there was a way of doing like an educational project around something in infectious diseases that I loved. And really the kind of area and ID that made me kind of fall in love with infectious diseases from the get-go always was tropical medicine. So, you know, here at Columbia, I think, you know, I met really kind of excellent people, Daniel included, also, you know, Rachel Gordon, which kind of really brilliant, like medical educator here. So, you know, we're, I always, you know, it was kind of my my passion to see if there was a way of combining those two, and seeing if kind of longer down the road there was a way of, you know, doing like a kind of curriculum around like tropical diseases, which I think it would always be kind of very valuable. But I knew kind of from the get-go that those things, like, you know, I needed to like learn much more myself, and kind of also, you know, like see more and more patients. I think I was also kind of really lucky to, you know, kind of connect with other physicians in the area, like physicians in, you know, sort of in Jacobi, like kind of really superb medical doctors, Christina Coyle. I think that also kind of hopefully will enhance that experience too. So, yeah.
Yeah. So you're creating, I guess, some kind of a tropical medicine online course experience.
Yeah, I think that's sort of, yes, that is the idea. So it would be kind of like a freely accessible online, you know, curriculum. I think that people can access and, you know, learn kind of as much as they could in that area. I think aim more towards, you know, people like in the kind of earlier stages in training, medical students and residents. Yeah.
So I understand you have a case for us. Is that right?
So actually, I think, Jorge, you were saying you had another recent case of leishmaniasis you wanted to tell us about. And then I'm going to give us the new case.
Okay, because I was going to say you just gave it away. You know?
Yeah, no, that's I don't think it would be fair to have two mystery leishmaniasis cases back to back. But Jorge, you had another case recently that.
Yeah, I think, you know, also this was kind of, it was a male in his kind of late 40s, kind of really similar pattern to the previous case, traveled to Tulum in Mexico. and did a lot of sort of touring around woody areas, and then about 4 months after he returned, noticed like a painless nodule behind his left knee, and kind of similar pattern of the story. Got multiple courses of antibiotics with no improvement. This case, sort of the first biopsy, also showed again, like cutaneous leishmaniasis, and then the PCR also revealed Leishmania mexicana. This patient was also treated with moltefusine, just kind of for two reasons. I think the first one was, I think there was a lot of kind of patient preference to this, and also the lesion. Well, three reasons. And the second is that I think the lesion also was quite large, about 4 centimeters. And in the course of, like, while we were waiting for the results of the PCR, the lesion started to develop some like subcutaneous nodules around the actual lesion, which kind of made the lesion a little bit more complex, and it was quite close to one of the tendons in his popliteal area. So the patient also, sort of did well on moltefusine, kind of similar to the other patient.
All right. Well, I do have a new case, Vincent, if you were worried.
I'm always worried. Yeah.
All right. Well, let me give you a new case, and then we'll let you catch your train. So this is a recent case. I don't, for listeners are aware, but I spent much of December, about half of December, in Tanzania, hanging out with the Maasai and the Serengeti, and up in the Ngorongoro caldera area, and at one of the hospitals in Arusha. Now, I want people to actually spend a little time. So I'm in Arusha, starts with an A, Arusha. I think it's A instead of U, Arusha, A-R-U-S-H-A. You're up at, I'm hanging out with Europeans, so you're 1,800 meters, so you're about 6,000 feet. So we're at elevation. I want people to keep that in mind. And a 28-year-old comes in. And this 28-year-old is actually, he is from a well enough socioeconomic situation where he has gone off and been visiting for the last 3 weeks, about 3 weeks. He's been visiting game parks. So we're up by the Serengeti and a couple of these other places. So, maybe he's been a little bit below that altitude. That might be relevant for exposures. But comes back, and now he's developing fevers, malaise, bad headaches, general body aches, somewhat somnolent. Just basically, he feels very sick, ends up in this hospital. Okay. So initially they think, we're in sub-Saharan Africa. We're here in Tanzania. We've got fever. It's funny. We think about returning traveler. I guess he was a returning traveler to Arusha, and they do the blood smear. They do a couple of blood smears, completely negative, no malaria parasites, right? Which is interesting, right? Because a lot of folks at lower altitudes in Tanzania, that's a hint, will have incidental parasitemia. It won't actually be what's going on. They do an extensive workup. They don't find anything, and they feel like, let's go back and let's do another blood smear because this just doesn't make sense. They get that history. This time they do a blood smear and they see something extra erythrocytic. And then they get the diagnosis and send this gentleman to a referral hospital for treatment.
So this gentleman is HIV negative, I presume?
He's HIV negative, no known prior medical, no prior surgical, no toxic habits, no significant family history. The exam was relatively unremarkable, other than the fact that he just feels sick, he looks sick, he's somnolent, he just looks like someone who's got sepsis of some sort.
How long before he's admitted did these symptoms begin?
They'd been going on for about a week, so it was pretty quick. Pretty quick. Came back from his trip, sick for about a week.
Did he remember any painful insect bites?
Well, that's a good question.
He's not going to answer that
Okay,
one.
I'm not going to get an answer. That's an answer too.
Yeah, it is.
He may have remembered a painful insect bite.
Right.
And hasn't been eating anything exotic?
No, nothing out of the ordinary.
Okay. And does he live alone?
So he's in his 20s. He actually still lives with family.
And everyone else in the family is okay?
Everyone is okay. Other people, it was a family trip, this safari trip. No one else got sick, just him.
Huh. Okay. Now, I don't know what it is yet. I have to think about it. It's not like the last one where it came just like that.
Yeah, just sleep on it and maybe buy
I think Jorge
Sorry,
knows.
I shouldn't laugh.
I think Jorge knows what it is.
Yeah, I think I have a good idea too.
Okay. That is, we're going to save your hero for next time, Christina, because this one you need some time. I don't want to rush you.
Yes, absolutely.
Okay?
Yeah, I did note it down, say for next time. So I think it's important that we spend some time on that hero.
That's TWiP 251. You can find show notes at microbe.tv/TWiP. If you want to send in guesses for this case, send them to TWiP@microbe.tv. Put TWiP 251 case in the subject line. That's why we know which one you are guessing about. If you like these programs, these science programs, consider supporting us. Go to microbe.tv/contribute. Our guest today from Columbia University Irving Medical Center, Jorge Cardenas. Thank you so much for joining us.
Thank you. Thank you for having me.
And good luck in your career.
Thank you. Thank you so much. Really nice meeting you.
You too. Daniel Griffin said Columbia University Irving Medical Center, parasiteswithoutborders.com. Thank you, Daniel.
Oh, thank you. And everyone, be safe.
Christina Nalla is at Glasgow University. Christina-Nalla.bluesky.social. Thank you, Christina.
Well, thank you. That was a fun case. And thank you, Jorge, for coming along and talk about it.
I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. Okay, Jorge, I'm going to ask you to help me sign out. I'm going to say, you've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon. And then you say another TWiP is parasitic. Okay? You got that?
Pressure.
Okay. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.